bác sĩ Bắc Chin Ken. Thì các bác sĩ giải phẫu Việt Nam đã từng quen biết báo cáo viên này rồi vào năm 2019 trong cái hội thảo giải phẫu bệnh lần thứ 12 tại Đại học Y Dược Thành phố Hồ Chí Minh. Thì báo cáo viên là cái người ngồi thứ hai bên trái đang giơ hai ngón tay lên đó, rất là quen thuộc và thân thiện. Thì anh đã tạo một cái ấn tượng rất là tốt với cái bài báo cáo về tế bào học ở trong hội thảo lần thứ 12 của chúng tôi. Thì báo cáo viên là một người hoạt động rất là nổi tiếng trong lĩnh vực tế bào học. Anh là giám đốc của ngân hàng sinh học của đại học của bệnh viện Jiangxi ở Đài Loan, là assistant professor của bộ môn khoa học thẩm mỹ của đại học Jiangnan Đài Loan. Về ban điều hành hôm nay thì gồm có tôi và tiến sĩ bác sĩ Võ Thị Ngọc Diễm. Tiến sĩ Diễm đã tốt nghiệp tiến sĩ tại Đại học Shiga, Nhật, là một giảng viên trẻ của bộ môn mô phôi giải phẫu bệnh Đại học Y Dược Thành phố Hồ Chí Minh và là một đồng nghiệp trẻ rất xuất sắc của chúng tôi. Về cái sự tổ chức của cái buổi hôm nay thì ngày thứ Bảy các bạn đã nhận được cái bản dịch bằng tiếng Anh, bản dịch tiếng Việt của bài báo cáo cùng với cái link để đặt câu hỏi. Thì nếu các bạn có câu hỏi thì các bạn sẽ gửi nó cho chúng tôi qua cái link này, thì đã được gửi tới các bạn trong group Zalo rồi. Các bạn sẽ kéo lên phía trên để xem. Còn những ai mà cần cấp chứng chỉ CV đó thì các bạn sẽ phải làm một bài post-test và phải đạt điểm 7 thì mới đủ điều kiện để cấp chứng chỉ CV. Về cái chứng chỉ CV đó thì tí xíu nữa sẽ có thông báo trong group sau. Cái link post-test đó thì chúng tôi sẽ lưu cho đến Chủ nhật thì mới đóng, và sau Chủ nhật đó thì chúng tôi sẽ bắt đầu tính kết quả. Như vậy thì tôi chúc tất cả các bạn có một buổi sinh hoạt khoa học rất là bổ ích. Chúc các bạn có một buổi chiều vui vẻ. Thì trước khi mà bác sĩ Bác trình bày về cái bài của bác sĩ Bác đó, thì tôi sẽ nói một chút xíu về cái hệ thống beta trong cái tế bào học của tuyến giáp. Thì hệ thống này được xuất bản lần đầu tiên vào năm 2010. Tới năm 2017 thì người ta đã ra một cái phiên bản thứ hai. Theo hệ thống này đó thì nó có chia ra làm 5 nhóm tế bào học. Nhóm 1 là không chẩn đoán được hoặc là không đạt tiêu chuẩn đi chẩn đoán. Nhóm 2 là lành tính. Nhóm 3 là có tế bào bất thường nhưng mà không có ý nghĩa xác định. Nhóm 4 là tân sinh dạng túi tuyến hoặc là nghi ngờ tân sinh dạng túi tuyến. Nhóm 5 là nghi ngờ ác tính và nhóm 6 là ác tính. Thì cái hệ thống này đã giúp cho có sự thông cảm lẫn nhau giữa bác sĩ giải phẫu bệnh và bác sĩ lâm sàng. Cái nguy cơ ác tính thì trong các nhóm này như thế nào? Theo thống kê của cái hệ thống Bethesda đó thì nhóm 1 nó có tỷ lệ ác tính là từ 5 đến 10%. Nhóm 2 nhóm lành tính thì từ 0 đến 3%. Nhóm tế bào bất thường không xác định thì từ 10 đến 30%. Cái nhóm 4 là nhóm nghi ngờ tổn thương dạng túi tuyến thì tỷ lệ ác tính nó từ 25 đến 40%. Nhóm nghi ngờ ác tính là 50 đến 75%. Còn ác tính là từ 90 đến 99%. Như vậy thì các bạn thấy là mặc dù tế bào học chẩn đoán là ác tính nhưng mà nó cũng vẫn có 1% là lành tính trong đó. Trong thực tế thì tại bệnh viện chúng tôi là bệnh viện Đại học Y Dược thì chúng tôi bắt đầu áp dụng triển khai kỹ thuật FNA từ năm 2002 và năm 2015 thì chúng tôi áp dụng cái hệ thống Bethesda Thì như vậy ở đây chúng tôi rất là thận trọng trong cái việc chẩn đoán ác tính, tức là ác tính chắc chắn thì chúng tôi mới chẩn đoán. Và như vậy thì nó lại rơi vào cái âm giả quá nhiều. Trong khi cái nhóm 1 á, theo hệ thống FNA đó thì nó chỉ có 5-10% thôi, thì chúng tôi nó lên rất là nhiều. Nhóm 2 thì người ta từ 0-3% thì chúng tôi lên đến 30%. Cái âm giả này đó thì sẽ do nhiều nguyên nhân, mà tí xíu nữa trong bài báo cáo của bác sĩ Mát thì sẽ có phân tích kỹ. Nhóm 4 chúng tôi thì tỷ lệ ác tính rất là thấp, trong khi nhóm 5 và nhóm 6 của chúng tôi cái tỷ lệ ác tính rất là cao, lên tới 90 mấy % luôn. Thì như vậy thì sao? Thật là tôi thấy không phải đơn giản là để cho mình đọc để mình chẩn đoán một cái kết quả cái bộ học chính xác. Như vậy thì những yếu tố nào nó làm ảnh hưởng cho cái kết quả của FNA, và những đâu là những cái cạm bẫy, và đặc biệt là trong nhóm 1 và nhóm 2, và những bác sĩ lâm sàng, người có trách nhiệm điều trị cho bệnh nhân, thì người ta có chia sẻ cái khó khăn này hay không, hay là người ta chỉ thấy là đó là lành tính, là theo lành tính. Và như vậy thì khi người ta nhận được một cái kết quả FNA, cái bài học đó là nhóm 1, thì người ta bỏ qua luôn, người ta cho là lành tính, cần cho bỏ qua luôn. Thì như vậy là có đúng thực tế, như vậy là có đúng hay không? Thì cái này thì tôi nghĩ hôm nay cũng có các bác sĩ lâm sàng ở đây cũng vào trong cái nghe cái này, thì các bạn sẽ phải cân nhắc lại để xem những cái mà lúc 1 đó, thuộc nhóm 1 mà không đạt đó, nó cần phải làm lại, cần cái gì thì các bạn sẽ theo một cái guideline. Và trong thực tế thì tôi cũng đã gặp một số trường hợp khi trả lời nhóm 1 thì các bác sĩ khoa lâm sàng không cho làm lại, mà cho qua luôn. Thì cái này là thực tế là có. Thì sau đây thì tôi kính mời các bạn nghe bài báo cáo của bác sĩ Maxim Chen, một chuyên gia nổi tiếng trong ngành tế bào học. Và để tránh không có bỏ phí thời gian đó, thì các bạn có thể vừa nghe vừa đặt câu hỏi thông qua cái link dưới đây. Cái link này đã được gửi qua cho các bạn rồi, và ở đây tôi cũng có lặp lại ở đây á. Thì ở đây chúng tôi sẽ dịch và chuyển cho báo cáo viên đây. Thì báo cáo viên sẽ trả lời sau khi kết thúc báo cáo. Bây giờ thì chúng ta bắt đầu nghe báo cáo.
Good day. I'm Mark. It's a long time to see you. I haven't been in Finland for 2 to 3 years. I'm really looking forward to visiting Finland, Ho Chi Minh so soon. And today I would like to give you a special talk about the common diagnostic people for thyroid FNAs. And I'm now the president of Taiwan Society of Clinical Cytology. Next year I would prepare for an international meeting, so I will forward the information and some artifacts or some over-interpretation. So the false positive and false negative can result in different outcomes. The false negative, we will miss the case, so we will delay their treatment. But for the false positive, we will give the unnecessary survey and even resection. So do direct harm to the patients. Both of the scenario we should avoid it. So according to the meta-analysis, the false positive grade is about generally summarize all the published studies. The general false positive rate is around 4%, and about 5% is their false negative rate. So I think at least for 4% or 5% is still better a lot, especially for individuals. But we should lower our false negative, false positive cases as best as we can. So we should know where the errors come from. The pre-analytic may be one of the major contributors. The pre-analytic could be incorrect analysis ordered. For example, they order the lymph node FNA, but they sample on the thyroid, and the opposite also occurred. They found the thyroid problem, but the sampling is to the trachea or to the lymph node. So the order may be wrong, the sampling may be wrong, and the request may be wrong, and the patient identity maybe goes wrong, especially when they are processing a lot of patient sample. We should be more careful to label their identity correctly, and the preparation should be appropriately, especially not to create too dry or too crushed slice if they do the direct means, and mislabeling should be avoided. Sampling collection should be correctly and appropriately, especially if you do the liquid phase cytology. You should collect your sample as fast as you can. And transportation is also another point that error may come, especially the transporter may mix up or may give the transportation labeling into the wrong position. Anyway, transportation can be another issue. So the pre-analytic may occur the errors very often. But in the lab, during the analytic, we should care about we cannot do the sample lost or mix up the samples. Or sometimes maybe our equipment may be failure. So maybe the tissue cellularity is okay, but after processing, the cellularity decreased. So if this point comes from over and over, our analytical problem will be very serious. So you should train your staff to do their best to collect and to process the tissue appropriately. And don't mix up the samples, especially our samples may be some cases may be malignant, some cases may be not. Don't mix up them together and avoid the contamination. The environmental contamination and the body contamination can be avoided by your processing or by some liquid-based solutions to lower the contaminations. And then the processing should be appropriately done. Don't make them follow their habitual process, not our standard process. Everybody's habits are different. Sometimes performing histiocyte or the blood only, you will think maybe this is non-diagnostic sample. And sometimes you see very abundant colloid. It means maybe it's non-diagnostic, but this can be a colloidal goiter. And if you only see histiocyte only or a cellular, it's definitely a non-diagnostic and unsatisfactory sample. Such cases have been evaluated in many articles. I will point out the Kuma Hospital's article. The Kuma Hospital points out the cystic-free only compared to the other non-diagnostic cases. The cystic-free only turned out to be less proportion of papillary carcinoma. The other non-diagnostic cases have higher proportion of malignant cases, either in papillary carcinoma or the other follicular carcinoma, mixed carcinoma, or parathyroid adenoma, such as that. So, for the cystic-free only, I think we should evaluate the ultrasound to confirm if this lesion is definitely a cystic lesion. You can observe this for a while and take the FNA maybe 1 year or 2 years after. But if they are not diagnostic and the lesion is not cystic, you should evaluate and repeat the FNA because the malignant rate is definitely dominant than cystic-free only. So, for the non-diagnostic, if you just see the colloid, it's maybe okay because the malignant rate may be very I think it's relatively low or not. But if they are non-diagnostic others, you should evaluate their ultrasound and do the FNA again to avoid the missed cases. And in the pre-analytical issues, we also include some cases of artifacts. Because artifacts, such as dry artifacts, can make our nuclei very large and very dark. You cannot easily recognize the detail because they get dry. So you will see somewhat most of the nuclei are a bit bizarre, a bit irregular because of the dry artifacts. So the dry artifacts will cause the loss of the cellular details and make a nuclear enlargement and nuclear TP. So if the artifact is dominant, you will easy to get the cases into atypical cells or even more severe. So please, during the preparation, you should train the clinical doctor to prepare the slice as soon as they can, to put the slice in the alcohols as soon as they can, because too dry will make our problem. And then, if you see the overstaining in dry stain, the dry stain is very dark and very blue. If the staining is very overstained, you will easily difficult reading these cases because the overstaining will cause the nuclei very dark, very black. So we cannot to figure out the nuclear changes easily. Especially if you got some cases such as diffuse sclerosing variant. This will be the dark staining will cause some problems, especially lymphocytes are also dominant. So the dry staining such as Romanowski stain, quick MGG GIMSA, right stain, new stain, they are not easy to well visualize. So to avoid this kind of, skill problem, the Kuma Hospital encourage most of the clinical doctors to do the pararadical aspiration, which essentially puncture the lesion, not perpendicular, vertical to aspiration the lesion, especially in isthmus. In the isthmus, they are directly ahead of trachea. So if you puncture too deep, the trachea cells will be included. And then, except some foreign body appear in our aspiration, the aspiration fluid also has some meaning. If you want to detect the lymph node metastasis of thyroid cancers, the aspiration fluid can be sent for test the thyroglobulin. Either the thyroglobulin is high or low. The thyroglobulin can be detected in lymph sphere perpendicular, you can see the colloid, watery, or the dense. And totally watery would be like this one. They will get some glass-like whisks. And dense colloid would be very, condensed and eosinophilic. But in the liquid-based preparation, the dense colloid would get more eosinophilic and more fragmented, and the watery background would be disappeared into very small, waxy fragments. And you can see the watery colloid in liquid-based cytology. They will get into small degenerative fragments, just like artifacts or degenerative debris. So they are totally different. So you should get used to adapt them. And in perpendicular or Hashimoto's thyroiditis, you can see the lymphocyte predominant background. But the liquid-based preparation, the follicular cells are here, but the lymphocytes are diminished. So the lymphocyte background will be very limited because the liquid-based preparation would diminish the lymphocytes of the background. And about the multinuclear aided giant cell, in the perpendicular we can easily recognize and pick up that art. But for the liquid-based cytology, the multinucleases will get more and more condensed and aggregated. So you should more careful to read them out. And about the papillary carcinoma, you can see the perpendicular staining. The papillary structure is very dominant, just like a tree. And the papilla is sometimes very big, just like a baseball bat. But if you put that into liquid-based preparation, the papillary structure will be very fragmented, and the papillary structure will be in a more flat and more condensed, more hyperchromatic nuclei. So the arrangement changes a lot, and the nuclear, would be less subtle. You can see in the nuclear changes in papillary carcinoma in conventional slice, the nuclear change is just like the same. The grooving is very permanent. The inclusion is easy to pick up.
Có mỗi cái nhìn
But
có thể
if you
lùi
do
mà
the
nó
liquid-based
trên ra
preparation,
thấy nhìn có thể
the
lùi
grooving may be
nhưng mà sao cắt ra không
very
thấy biết.
mild to moderate, very subtle, and the inclusion sometimes are not easy to pick up. But their nuclear changes are, generally get more signal. So compared to the raw cell, in the liquid-based cytology, if you get some cells in spindle-like shape, we should pay more attention to read the nuclear changes, include the grooving and include the pseudo inclusions. starts the nuclear grooving, but not so, not every nuclear gets permanently grooving, and make us overdiagnosis these cases. And acoustic change is very often in Hashimoto's thyroiditis. Mostly will cause the nuclear enlargement and cytoplasm get very abundant. So generally the cell would be getting enlarged. So a large cell with nuclear epithelium would be easy to put them into a typical cell at least. So the lymphocytic thyroiditis are easily to make the cases into severe or atypical categories. However, because the Hashimoto's thyroiditis have higher papillary carcinoma association compared to the other issues, so sometimes it's very tricky if you read papillary carcinoma in Hashimoto background because they easy to cause the nuclear changes, but they also have higher malignant associations. So the diagnosis interpretation is totally based on your experience and your reading. You should read these kind of cases carefully. The Hashimoto's thyroiditis mostly, they are in the background with heterogeneous lymphoid population. But the other differential diagnosis would be the lymphoma. The lymphoma include the myeloma or diffuse large B-cell lymphoma. They are easy to be monotonous population. So you should, if you do the conventional slides, you just need to carefully read the background cell about their heterogeneous or monotonous and their variation and their lymphoid proportion. If the lymphoid proportion is dominant and they are monotonous, you should mention the possibility of lymphoma and put this case into at least the typical cells and warrant it then to do the lymph node or the lymphoma studies. And then I will go through some cases of special cases. The first case is 56 female, a right thyroid tumor. You can see the right thyroid double part here, and the tumor is over here. The tumor is around 3.7 to 1.1 centimeter, and you can see the tumor is well defined with relative hypoechoic texture. The tumor didn't have calcification, and we do the conventional molecular stain. You can see the background relative is have a lot of naked nuclei, and the structure is relative into papilla or sheets-like structure. follicle-like structure, but didn't have colloid. And the other part, you can see some small microfollicle-like structures, some flat sheets, and the background lymphocytes. And look into the highest power, you can see, yes, maybe these are, degenerated cell, and maybe these degenerated degrees or colloid, but I didn't see the colloid in the microfollicle, but the nucleus is very wrong, and even pepsol-like chromatin. So if you see, a structure in a solid sheets or papilla-like structure, but you didn't see the nuclear changes of papillary carcinoma, they are wrong and pepsol-like, you should consider parathyroid. Because the parathyroid always have a very wrong and oval nucleus, and their chromatin are usually very pepsol-like, very fine, and their nucleolus is not so prominent, and their cytoplasm is limited, always mild to moderate. So they are looking like carcinoid tumor, but without any prominent TP. So this is very high power. You can see the chromatin is very fine, and cell-to-cell border is indistinct, and the cytoplasm is relatively pale, and we didn't find any confidence colloid, even though this is microfollicle-like. So what's your answer? What's your diagnosis of FNA? If I do the interpretation, I will say maybe they are a typical cell, and I favor it's a parathyroid region, or into benign, and mention maybe they are, parathyroid region with especially parathyroid adenoma, but I'm not so sure they are parathyroid carcinoma or others. Or if you can put them into follicular neoplasm because the severity is relatively higher, and you are not so confident they are not follicular cell. If you think they are follicular cell, you can put them into follicular neoplasm. But you should not put them into suspicious because their nuclear changes are not like papillary carcinoma or oncocytic carcinoma or follicular carcinoma, and positive even far. And we do a cell block. The cell block tells us, yes, they are eosinophilic cell with wrong uniform nuclei, and sometimes you can see the follicle-like structures, but without colloids. And we do the chromographing. The chromographing is positive, so they are parathyroid. You can also do the synaptophysin or the gamma-3. The gamma-3 is very useful, especially as a nuclear staining. Nuclear staining is more, trustful and reliable because cytoplasm staining such as chromographing sometimes would be heterogeneous or not easy to be stained in the ICC. If you do the ICC, you can do the they are composed of cystic changes and follicle-like structure and clear cell changes, oncocytic changes, but the nuclear changes are very fine. You can see the nuclear changes are always long, oval, and episode-like. So we would recognize the nucleus not by the cytoplasm. The cytoplasm may be clear, may be eosinophilic, but the nuclear changes are always wrong, uniform, chromatin is fine. So if you want to recognize parathyroid cells, please look at their nucleus. So this is a parathyroid adenoma, and clinically they have very high calcium, free calcium. The characteristic for the parathyroid cell will be uniform round cell with distinct borders, pencil-like chromatin, and indistinct nucleus. And mostly they are cohesive solid sheets or micromolecule-like structures without colon. And for the staining, you can do the TTF1 to exclude the thyroid cell, and gamma-3 to include the parathyroid cells. And you can also do the neuroendocrine markers and PTH. But PTH is not commercially available. And this is a table to tell you how to differential diagnosis parathyroid adenoma, papillary carcinoma, or follicular carcinoma. Mostly their cellularity are hypercellular. And patterns sometimes may be very overlapping, especially for follicular lesion to parathyroid. They have superficial solid structure, and bare nuclei. Bare nuclei is not easy to occur in thyroid follicular lesions, but bare nuclei are frequent in parathyroid adenoma. Papillary carcinoma, you can recognize its nuclear changes, and the bare nuclei is not easy to be found. And the structure also, papillary carcinoma has papillary structure. Parathyroid are mostly overlapping nuclei. Paravascular arrangements will be mimic papillary-like structure. Superficial solid will be overlapped with thyroid follicular lesions, especially these parathyroid to follicular lesions. And the nucleus of cells are the biggest difference. The parathyroid will be small and monotonous uniform, round, but the papillary carcinoma has, enlarged cells with ground-glass nuclei and nuclear groups with pseudo-inclusions. So the follicular cell will be enlarged and have very coarse chromatin, not fine chromatin. And the cytoplasm is relatively scanty, and sometimes will be eosinophilic, depends on its oncocytic changes, happen or not happen. And the background colloid should be happen in papillary carcinoma and follicular carcinoma, but not present in parathyroid region. You can see sometimes some protease material is because of the hormone secretions. Okay, let's go to the case 2. The case 2 is thyroid FNA from a 39-year-old female right thyroid lesion. You can see the anti-thyroglobulin is very high, the thyroglobulin is low, and the free T4 is normal, TSH is normal. So this case is autoimmune thyroiditis case. She has multiple hypoechoic nodule, and with unclear margin and heterogeneous find some, some conclusions. So what's your answer? I think this case is very difficult because this is an autoimmune thyroiditis case. Autoimmune thyroiditis can cause nuclear TP. So this nuclear TP may be regenerative active. But the echogenicity and the ultrasound findings tell me this whole thyroid gets some heterogeneous spots, calcify or fibrotic. So maybe the calcify and fibrotic area cause some problem of the aspiration. So we cannot get so many hypercellular cells. So I can only read this case upon these clinical cells. So I will recite it out as a clinical cell because I am not confidently sure this case is not malignant. And this is the recession right thyroid. It's very firm and the texture is very hard and relatively white. And after resection, you can see they are fibrotic, have a lot of hyalinized stroma. And the lymphocytes are very prominent to cause lymphocytic glucose follicle. And the thyroid follicles are relatively atrophy and get some, Herschel cell-like changes. And the other, picture tells us, yes, the sclerosing background is prominent. And look into the high power, you can see the nuclear changes is prominent. They got enlarged nuclei and visible nucleolus and irregular nuclear shape. And you can see a lot of lymphocyte-like infiltration, and mostly are plasma cells. These plasma cells make me very curious. These plasma cells are normal plasma cells or IgG4 thyroiditis? Because the IgG4 thyroiditis can happen. Hashimoto thyroiditis, rhinothyroiditis. This case may be like a rhinothyroiditis, but the rhinothyroiditis, the sclerosing should be very prominent, and fibrotic bands should be into the adjacent organs, just like trocheas, muscles. So this case is lymphocytic thyroiditis with prominent lymphoplasmacytic infiltration. So you can see many plasma cell-like cell infiltrates and prominent nuclear polymorphism. And we do the IgG4 stain with the ultra-fast rate for the second label antibody. You can see dominant infiltrate of IgG4 positive cells. I think every high power is over 50 cells. So this case was started out as IgG4 related fibrosing variant of Hashimoto thyroiditis. The Hashimoto thyroiditis, they get very prominent fibrous expansion, sclerosing background, can be fibrosing variant. And the IgG4 related thyroiditis should be fulfill some criteria, and the IgG4 related thyroiditis can be covered into the rhinothyroiditis, fibrosing variant of Hashimoto thyroiditis, or IgG4 related Hashimoto thyroiditis, or Graves' disease with elevated IgG4 level. And the criteria of IgG4 related thyroiditis would be enlargement of the thyroid. Yes, this case has enlargement of the thyroid. by the ultrasound, yes. Elevated IgG4 level over 135. This case is not detected because we didn't measure by the biochemistry. But histology, yes, they have formed IgG4 positive plasma cell over 20 cell per high power field, or the ratio to the IgG plasma cell will be over 30%. And so this case is really probable probable case of IgG4. So, if you see some, Hashimoto's thyroiditis, you should check out for the IgG4 positive cell, especially when the plasma cell are prominent. Okay, let's go to the case 3. Case 3 is the thyroid FNA from 36 us.
nha.
They have very
Đó,
prominent,
nó cái đầu móc
this
này.
kind of case have very prominent
Trong cái túi hồng hồng đó.
actual capsules
Dạ
weight
túi,
and
chỗ túi sách máy đó.
immunization. Very common,
Không,
but
trong đó
they
có
get
cái
to the
đồ
disease
bọc đồ
outcome.
bóc tay.
It's very tricky. They are not easy to be found in Hashimoto's thyroiditis. Their mutations are not commonly detected. Especially, they didn't share the common mutations of papillary carcinoma, such as BRAF. They didn't have BRAF mutation. And they didn't have MAML2, because the MAML2 mutations often occur in salivary gland mucoepidermoid carcinoma. So the SMAC is a distinct entity. They are believed to be a rise in the solid cell nest. Okay, let's go on the next case. The next case is a 69-year-old female. The right thyroid tumors. The right thyroid got two nodules. One is here. The two is here. They have a central hypoechoic area. But the nodule 2 is relatively complex and get some calcified spots. But the nodule 1 is relatively homogeneous. This is the aspiration from the nodule 2. The nodule 2, the perpendicular staining shows some, the papillary structure, some papilla-like, and some fat adipose cell-like, cells. And the high power, you can see, yes, the nucleic grouping is very prominent, and inclusion is here. So the nodule 2 may be a papillary structure, it's a papillary carcinoma. And this is large adipose cells, And in the liquid-based study, you can see some skeleton muscle. And this is papillary structure of tumor. And in the high power, you can see the grouping is here, This is the papillary carcinoma, especially compared to the conventional. We see the inclusions. And the other part, we can see the bubble gum-like inclusion. Yes, we can figure out.
Đợt trước mình cũng thấy thể dùi quá trời nhiều luôn mà tại sao đi cắt ra không thấy ta?
And the new stem, we also do the new stem. The new stem also see some sugar inclusion here. And the structure is relatively papillary structure. Yes, you can see some
Có rãnh nữa kìa.
inclusion and inclusion.
Đúng
So
rồi.
the nodule 2 is a papillary carcinoma. So what's your answer? I think this case is very easy. The nodule 2 from our exploration of 3 different preparations, just want to tell you one truth. It's possible for malignancy. It's a papillary carcinoma. But our story is not based on the nodule 1. Well, it's not based on the nodule 2. Our story is on the nodule 1. The nodule 1 is a twisting lesion, but you can see the nodule 2 is papillary carcinoma. Yes, the growth is perfect. But the nodule 1 is a fat-like structure. It's just a cystic and adipose structure. But adipose-like content. Sorry, not structure. Content. And then you can see the nodule 2, yes, it's a papillary carcinoma. Here, in the low power, the high power. And you can see some calcified spots. And BRAF is positive. But the nodule 1 is a cystic lesion, but the content is thyroid and adipose tissue. The adipose tissue one of my best friends. We are very close friends. But it's a pity to meet him, especially in prison 3 years. Because I cannot attend USCH, so I don't meet him in person during the prison 3 years. But I put this case, share this case to them, and Dr. Cook write this case, and I propose this case, submit this case to diagnostics, and eventually next year it was published.
Thích thấy hả?
So I would like to appreciate their cooperation and our connection
Có
in
6
the
thôi,
mission.
có 6 thôi.
I would like to thank you joining my talk, and I could encourage more Vietnam pathologists and young pathologists to share your case and study with me if you want to publish more and more international articles. You can find me, and I will be always to help you. Thank you. This talk is coming to an end. If you want to figure out more diagnostic pathway with multidisciplinary discussion, you can check out this checklist. And then I would look forward to joining our South Vietnam meeting as soon as possible. Thank you for your friendship, and be safe, be healthy. Good night. See you. Bye.
Xin cảm ơn phần trình bày